Hello, everyone. Hi, my name is Swapnil. I'm from Critical Care Education and I work as a staff specialist in St. George Hospital in Sydney. Welcome to this new episode of podcast series called as Hot Cases. And in this podcast series, we are going to discuss how to approach a hot case for College of Intensive Care Medicine fellowship preparation exams. So without wasting too much of time, let's dive into today's episode, which is about introduction to hot cases. Often a lot of candidates come to me and ask that how to approach fellowship exam, particularly hot cases. What are the expectations from examiners? What structure should I follow in exam? And how really should examine the patient, and then how I should present my findings. So this video is going to address all those questions. So let's begin. The first and foremost important thing for fellowship exam preparation is understand the technique. If you don't understand the technique of exam, it's very hard to pass the exam. So it's very important that you know the technique and approach the exam in certain manner. Now, often in CICM fellowship exam, you will be asked to examine two hot cases, which are two real patients in intensive care unit, and you will be examined by two different sets of examiners. Broadly categorizing, when you are examining a patient in fellowship hot case, I usually categorize into three different stages. First stage is outside the room, which is also called as reading time. And often in this stage, you get 2 minutes time for reading the stem. The second stage is called as inside the room or actual examination stage. And at this stage, you often get around 10 minutes to examine the patient. And the third stage is again outside the patient room. Also, I call it as presentation stage, where you get another 10 minutes to present your findings, discuss your differentials, and answer the questions that examiners ask you in the first stage. So overall, the whole hot case goes roughly around 20 to 22 minutes. So let's dive deeper into the first stage, that is outside the room or the reading time stage. When you approach your fellowship exam on that day, you will be given the same as displayed on the screen in a very structured format. So you will have a 2 minutes reading time to read this template. Now, the key things that examiner will tell you about that patient: what is the name of the patient, what is the age of the patient or the sex of the patient, and how many days this patient is in ICU for. And that's the very crucial information, because the trajectory of any clinical illness will depend upon number of days that patient is in currently ICU. Because your approach to patient who is in intensive care unit for more than 2 weeks will be quite different than the patient who is in intensive care unit for less than a week. The next important information is what are the presenting problems or history of presenting illness that patient was admitted to intensive care unit. And again, examiners are trying to give you the relevant information at this stage so that you can start thinking about, okay, how am I going to approach this whole hot case? Examiner will also give you significant background history which are relevant to this case. And sometimes some of the chronic illnesses are quite relevant, because that will determine how you examine the patient, especially in your general examination stage. And the last couple of key information in this template is around what is the current state of the patient and what is the actual question. Now, all the information provided in this template is relevant and important. But the most important thing is the question that examiner are asking at the end of this template. Please make sure that you memorize two important things: name of the patient and what is the question. It's often challenging that in first 2 minutes to absorb everything which is given in this template. So it's important that you take a deep breath, gather your composure, read the information slowly, try to find out what's the relevant information out of all this information, And then memorize the name of the patient and the question that examiner are asking you to answer. Then once the 2 minutes reading time is finished, examiners will ask you to proceed with your clinical exam stage. Now, when you enter in the patient's room, usually the examination phase, which kind of takes place around 10 minutes, is classified into two broad phases. The first phase is the observation phase, which usually lasts around 1 to 1.5 minutes, and then followed by the clinical examination phase, which lasts usually around 8 to 9 minutes. Now, often, depending upon the unit policy and depending upon the patient's MRO status, you will be expected to wear full PPE, and you will be given the stethoscope and other necessary examination instrument at the time of the exam. And usually that will be done before your reading time starts. When you enter inside the room and when your observation phase begins, it's really important. First and foremost thing to do is go and greet your patient. Mr. Smith, good morning. My name is Swapnil. I'm one of the ICU doctor, and I'm going to examine you for next 10 minutes. I'm just going to take a look around first, and I'll come back and examine you a bit later. And that establishing the rapport with the patient is important. And almost you're informing the patient that what you're going to do for next 10 minutes. If the patient is conscious, awake, and not intubated or tracheostomized, then you are expected to also take a consent from the patient. So when you enter into the patient's room, the room may look extremely busy because there are a lot of monitors attached, there are a lot of extra gadgets attached. Always have a structured approach in this observation phase. You need to gather as much information possible in these first 1.5 minutes. There is no right or wrong answer how you should approach this observation phase, but having a set structure is the key. I often start with the monitor. I look at the monitor and interpret the waveforms and the numbers that I'm looking at the monitors. Rather than saying patient is currently having a heart rate of 110 beats per minute, it's important to say patient is currently in sinus rhythm and hemodynamically stable. Interpreting the information is the key. Often, some candidates like to verbalize their findings, while some candidates like to notice and keep it to themselves. And that's okay. Again, there is no right or wrong approach, but the information that you see on the monitor, it's important to synthesize that information into a meaningful comment. And that's the most important thing. So once I look at the monitor, then I move to ventilator. Again, when you move to ventilator, it's important to look at the setting, the mode, the FiO2, what's the compliance or resistance, and then also look at the waveform and then interpret the ventilatory findings rather than just reading out the settings. And the third thing is to look at the infusions. Sometimes it's very obvious that the infusions will be labeled very clearly in the bold letters. So you don't need to ask examiners what infusions are they. But it's important to clarify if you can't read, or sometimes the infusions are not running. For example, heparin infusion, NORAD infusion. And then in those cases, it's important to ask examiners how long these infusions have been ceased. And that's the relevant information for that particular case. Now, often some examiners might not like you asking a lot of questions around that bedside space in initial observation phase. So trying to minimize the number of questions that you ask is important. But also it's important to ask only relevant question to this case, rather than asking, tell me the trend of urine output, tell me the trend of blood pressure, tell me the trend of heart rate. A lot of information might not be relevant to that particular case. And that's why it's important to choose your questions that you can ask the examiner very carefully at this stage. Once you have gone through your monitor, ventilator, and infusion, then obviously start looking at what are some of the extra things are present in the room. Sometimes the patient will have devices attached, such as balloon pump, a continuous cardiac output monitoring, ECMO machine, dialysis machine. Again, spend some time to look at these monitors, spend some time to absorb the information and make sure that you interpret those numbers rather than just reading it out. Especially with the balloon pump, it's important to then put the balloon pump on 1:2, look at the waveform and see whether it's augmenting properly or not. Sometimes you might not have time to do that in first 1.5 minutes, but it's often you can ask that after you finish the exam. Then also look at some of the other important clues within the room, such as posters like difficult airway posters, MRO posters, some of the family photos in terms of long-term ventilated patients in ICU. All those things are important when you're observing and looking at the patient. Once you finish your observation stage, then you can approach the patient again and commence your clinical examination stage. Now, the clinical examination stage, usually you have 8 to 9 minutes to complete your clinical examination. I normally divide clinical examination into 3 different templates: neuro template, trauma template, and non-neuro, non-trauma template. You may ask me a question, why is that? It helps me to simplify my approach towards the clinical exam in each of these different cases. For example, any patient who is presenting with primary neuro problem, I use my neuro template, which basically starts with thorough neurological examination. And that means I will spend roughly around 4 to 5 minutes in examining neurology of that patient. And that will include thorough higher function assessment, cranial nerve assessment, motor assessment, tone, power, reflexes, and if time permits or if it's relevant to the case, then sensory examination. And that gives me at least that first 5 minutes to complete my thorough neurological examination. Then I will move to cardiovascular examination, then respiratory, and then abdominal examination. Sometimes if you run out of time and abdominal examination is not relevant to case, examiners will understand because you have completed a thorough neurological examination. With the trauma template, any patient who is admitted with polytrauma, I usually use my secondary survey to start with. Try to identify all the injuries that patient has sustained, and then based on the injuries, I will select which system to start with. So, for example, if the polytrauma patient has traumatic brain injury, then obviously I will begin with neurology exam. If the polytrauma patient has come with significant abdominal injuries, then I will commence with abdominal exam. So having that secondary survey done first helps you to then choose which system you're going to start with. Now, always remember, in trauma patients, assessing the C-spine is very crucial, because not assessing C-spine or not commenting on C-spine can be considered as a critical error. And the third important template, it's the non-trauma and non-neuro template. And most of the other cases, which are the most post-operative cases, for example, cardiothoracic patients or patients admitted with pneumonia, patients admitted with cardiogenic shock, all those other patients fall into this category. And for this set of patients, my approach is to start with general examination. So start with looking at fingers, clubbing, palmar erythema, go all the way from top, look at the neck, look at the face, eyes, mouth, palpate for lymph nodes. And once you finish your general examination, then begin with the relevant system examination. So if the patient is admitted with pneumonia, obviously you start with respiratory, then cardiovascular, then abdominal, and then lastly the neurology exam. So with having this kind of templates help you to structure your clinical exam, and there is not a lot to think about where to start, because often a lot of candidates struggle even initiate their clinical exam because they get confused which exam to start with. So having these templates and applying these templates to certain categories of patients help you to have some sort of structure and or building the hooks so that you can fall back on those hooks in case you are very nervous on that day. So at this stage, you have around total 10 minutes. And once you complete your clinical exam, examiners will provide you an opportunity to ask some of the other questions that you might want to ask at the bedside. Now, again, choose your questions carefully because you don't want to give a list of 10 to 20 questions to examiner at this stage. The relevant things to ask, I would like to look at temperature of the patient because sometimes on the monitors temperature will not be displayed. I would like to look at the fluid balance of this patient rather than just asking urine output of the patient because the isolated number of urine output might not be useful. And if you need some relevant information such as certain investigation in order to make up your mind regarding the questions that was asked initially, then you will say so, saying that I would like to look at the blood gas or ECG or certain imaging findings before I can answer the question. And that's very relevant because that's what we will do normally at the bedside round, that before we make a plan or management plan for this patient, we will like to look at the relevant information, combine that with the clinical examination, and then we'll come up with the plan. So often examiner will give you that opportunity to ask those relevant questions. So again, make sure that you choose those questions wisely and carefully. Once you finish your clinical exam, you'll be asked to take your gown and gloves off, wash your hands, and then you will move into the next stage, that is outside the room, also called as presentation stage. Now, the presentation stage can last around 10 minutes. And in this stage, you are expected to answer the question that examiners ask you at the very beginning of the exam. Now, there are various ways you can go about presentation. And again, there is no right or wrong way how you present. One approach is you start by saying, I would like to present my examination findings first, and then I would like to answer the question. And in that way, you again build some of the hooks so that it gives you some time to gain your composure, kind of calm your nerves, and then you can answer the questions much effectively rather than getting into the answer straight away. While the second approach, where you can start with the opening statement, where you answer the question up front if you're very confident, and then back up your answer with the relevant exam findings. And then you will have a discussion around why you chose this answer based on your clinical examination. And again, amongst these two approaches, there is no right or wrong answers. Both approaches are good. It depends on what suits you the best. And that's the most important. So develop a style that suits your presentation and then follow that style every time you are practicing the hot cases. Don't change styles with every single case. So stick to a structured approach of examination and presentation. If you like this video, make sure that you like and subscribe to YouTube channel. If you are listening on audio platform, make sure that you subscribe on iTunes, Stitcher, Spotify, or whichever platform you use. Also visit the website called as www.critcareedu.com.au. You will see a lot of relevant information related to fellowship exam and primary exams on this website. I'll be back in a fortnight's time. Stay tuned.